kinds of opportunities for role play, discussion, and those kind of things. So if you need to really take a deeper dive into it, which probably a lot of people do, ASAM, you can get their you can get that program directly from them. So I encourage you to do that. So let's see here. So this is the book. This is the third edition. I think Dr. Fink's on here. I think she has helped write some of the chapters for the fourth edition that'll probably be coming out sometime. Is that true, Dr. Fink? Are you on? There she is. Okay. So she may have some comments on the ASAM criteria. And so here are the objectives for today. We're going to interview particularly focus on the interview process for the ASAM criteria, placement criteria, the 6 dimensions, what those are. We're going to look a little closer into risk assessment today, and then try to understand the relationship between severity of illness, level of care. And I don't have any disclosures at this time. So here we are with the kind of the loop. So this is how this is intended to work. So we've got the biopsychosocial assessment, and those are the dimensions. And we'll talk about the 6 dimensions here in a minute, but it all begins with a good, thorough biopsychosocial evaluation. And then developing problems and priorities based on the 6 dimensions and the multidimensional assessment. Then based on the strengths, weaknesses of the patient, we come up with a plan. And then fourth, we're able to monitor progress based on the patient's movement in the 6 areas or the six dimensions. So we're able to provides us with a way to kind of judge somebody's treatment progress. So that's kind of the big picture. But like I said, it all starts with an assessment. And so as you probably know, we'll go over this a little bit, but this is kind of more comprehensive biopsychosocial assessment. It's sort of geared for substance abuse. And so I'll just walk through this with us. So initially you have the history of the present episode. So what's bringing you in? So, here you're thinking about predisposing factors. What are some factors in the background or historically that predispose somebody? What are the precipitating factors for this particular situation? So with the substance abuse person, it could be a relapse, or it could be that they've had to come into treatment. The precipitating event could be a wife left them. It could be an automobile accident. It could be nearly anything that would relate to their substance use. Why they're coming in today. Then you have kind of maintaining factors. What are some factors that maintain this problem? You might have some factors related to strength factors, strength and resiliency factors, that mitigating factors in terms of the illness. So those are kind of things you're looking at when you're talking about history of the present episode. And these are not really in order. If I was going to group them, I'd organize them a little bit better, but you'll see as we go through. So there's a family history. So this is just a history of the family. Tell me about your family and what's the constellation. So you might do a genogram. You might know who's been married to who, where the divorces were, who had substance abuse problems, all those kind of things that you would look at. If you were doing kind of a genogram initially being kind of the family structure, followed by key factors like who has illness, who has a substance abuse problem, who had a mental health problem, those kind of things. And then last piece, who died when and of what, and those kind of things, suicide, all those kind of things you put on for all the family structure. You put those nodal kind of significant events on there. And then the last thing you do, the third piece, is you look at the relation patterns between people intergenerationally and between generations. You look at those relationship patterns. So that'd be the kind of thing you'd be doing here, is just getting kind of the family history. And then for the patient, you'd want to look at developmental and educational factors, developmental problems. Did they stay in the hospital too long? Did she separated from her mother at infancy? Those kind of things. Educational factors, how'd you do in school? Any learning disabilities? Were you in accelerated classes? Anything like, did you get along with your teachers? Did you not get along with your teachers? Did you have friends? Were you involved in a band and other activities? So all those kind of developmental educational things. And then you're interested, of course, in substance use. And so what substance did you use? How long ago? How much? How often? All of those kind of things we're fairly familiar with. But you might also want to ask things about what did it do? What did you like about it? And what did you not like about it? And Did you use it in social settings or did you use it individually? Those kind of things. So a comprehensive look at their alcohol and tobacco and drug use. Social history here is going to be those kind of things. How to get along with people. Do you have best friends? And is there a lot of drama in those relationships? Has there been a lot of divorces and breakups, those kinds of things? Legal history for substance use, that's something to be important. DUIs, incarcerations, and how that relates to their substance use. So all of those kind of things would be important. And then work in military history. So where have you worked? How long? Of course, you're looking for things like people hop from job to job, or their substance use somehow got in the way of their job and they had to leave. I've worked with some people like traveling nurses and so forth and had substance abuse problems. And it seemed like they're, traveling, they would be on for 90 days someplace and then they'd be gone and they'd be home for a week or two or a month. And then they go somewhere else and they'd be there for 6 weeks and gone. So that kind of work structure kind of lended itself for substance use. Never there too long to kind of get in trouble. Always had an opportunity to kind of unwind once they got home, either straighten up or drink or whatever they needed to do, and then they were off to another one. So you're looking at those kind of things. Psychiatric history would be histories of depression, anxiety, hospitalizations, counseling, outpatient counseling. Sometimes people with substance abuse problems, they end up looking at, they kind of present as depressed or anxiety, but they're using substances underneath or behind that or in conjunction with that. And, you might look for things like opiate use and those sort of things. Childhood history is kind of like developmental educational history, but I put this in here because we need to really pay attention to traumas. This is like the ACE factors. So those 10 ACE factors, have you experienced a divorce, or was it somebody had a mental illness in your family, or were you physically abused or sexually abused, were you, intimidated, those kind of things, somebody in your family, suicide, a parent, did those kind of things. So those ACE factors, so we pay attention to those. So we know trauma is related to substance use. Family psychiatric history. So is there a family history of psychiatric or substance abuse problems, probably back to the third generation to the grandparents. And if you're doing a genogram, it's pretty easy to follow that, and you can begin to see the relationships. Medical history, and we kind of put review systems in here because it's probably a good idea when you're doing substance use stuff to go ahead and do kind of a thorough medical history. So you have stomach problems, you have any cancers, do you have cardiovascular problems, because all these kind of things that can be related to substance use and come into play pretty importantly when you're talking about intoxication or you're talking about withdrawal symptoms. So kind of a thorough medical history review of systems in terms of how the person's functioning overall. And then religious, spiritual history would be important because sometimes people get involved in AA or they get help through the church or through their family or those kind of things. And so taking the gauge in terms of somebody's, preference for religious or spiritual kinds of things, and they see that part of their problem and they see that part of their recovery or their treatment would be an important kind of thing to know. And not to mention that sometimes, unfortunately, trauma and abuse occurs in religious settings and contexts. So then a thorough mental status exam, of course, we would want to include that. And then the regular kind of things we look for in substance abuse, social work, psychology, those kind of things. So what are the patient's assets or strengths? And it could be everything. They have insurance, they have medical care, they have transportation until they don't have those things, which would be the psychosocial vulnerabilities. They don't have insurance, they don't have transportation, they don't have a place to stay. So you've pulled all your kind of history together, you've gathered your history, and then you're going to make some assessment about risk. And we're going to talk about a risk in terms of the 6 dimensions, ASAM criteria, and we'll talk about risk in terms of self-harm. And then based on that, you're going to come up with some of your formulation. So theoretically, how do you understand this person? And the 6 dimensions really helps you develop your formulation and your conceptualization of how you understand the patient. Then you're going to come up with your diagnosis and then your treatment recommendation. So it's important that you kind of follow, that we kind of follow that order. It's curious to me that sometimes, like in a residential program or something, after they accept the person into the program, then they do the evaluation, which seems kind of backwards to me. It looks like you could evaluate the person, determine severity of illness, level of care, and then refer them to the appropriate level of care. So the ASAM criteria helps us kind of do that and keep that in, keep it in the right order. So these would be the kind of things you would look for in elements of a thorough biopsychosocial evaluation. So here are the six dimensions. These are the kind of, like I said, conceptually in terms of your formulation, in terms of how you understand the patient. This really helps you organize your assessment, your recommendations, and kind of how you understand the patient. So we'll go over these here, and then we'll look at them a little later on, and then we'll try to apply them to some cases. But so the first dimension is this intoxication and withdrawal potential. So this is why the medical history is important. This is why the substance use history is important. So we want to know something about their level of intoxication and how intoxicated they get, and how they manage that intoxication, what kind of problems that intoxication may cause for. At the same time, we're also interested in withdrawal. So have you had withdrawal symptoms before? You know, are those withdrawal symptoms mild, moderate, or severe? And have you had seizures, or have you had, you know, other kinds of problems where you needed some medical attention, or you needed a medical detox? So those are the kind of things that we're looking for in terms of the dimension one, and that's going to be the effects of intoxication. How well does a person manage those, and the potential for withdrawals? And so we do that through history and through their past experiences with withdrawals. And then we're looking at, so dimension two has to do with comorbid kind of medical conditions. So we would want to know if somebody had cardiovascular problems, or if somebody had had seizure disorder, or if somebody had, liver problems, or all of those kind of things. And so we're looking here to know if there's any kind of comorbid medical problems that we need to pay attention to with the withdrawal, or sometimes with intoxication. So, so these are kind of things we're talking about. People are maybe medicating their withdrawals with some other kind of medication or some other kind of drug so that they kind of ease that, or they're, using some methamphetamine when they're coming down to kind of get them pepped up. And so, we'd want to know about those kind of things and what kind of risk that poses, or what kind of biomedical conditions they may have that would be influenced or put them at risk. Dimension three is going to be like behavioral and emotional kind of comorbidities. So these could be things like mental health problems like depression or anxiety. It could be problems like psychosis. It could be problems with impulse control. It could be any number of post-traumatic stress would be another one we would think of. So this is really how their mental health, that being their emotions, their behaviors, and their cognitive functioning. Dementia would be another one we'd be interested in. How all of those would affect their substance use and their potential recovery or treatment. The readiness for change, dimension 4, is really going to talk about how ready they are. So we'll talk about that here in a little bit more detail in a minute. But that is, and this is an important one in terms of where somebody is on the continuum of readiness. Because that has a lot to say then about, what kind of treatments you need to steer the person towards. Dimension 5 is going to be relapse or continued use. So what's the risk or the potential for relapse? And so that really kind of is related to all those, 4 factors above it. But you would come up with some kind of guesstimation in terms of what their risk for relapse or continued use is going to be. And then the 6th one is going to be recovery environment. So where are they living, and are they in a situation where they're going to be living, there's going to be little opportunity for relapse, or is there going to be a situation where they're going to be multiple opportunities for relapses? Is their treatment of their sobriety or their recovery going to be supported by their environment or not supported by their environment? So these are the 6 dimensions then that help us kind of organize the data that we get in our biopsychosocial, and kind of help us formulate kind of our plan and how we understand the patient. Now, I'll tell you, we talk about this in a little more detail. So this is the readiness for change scale or paradigm. And so I'm sure y'all are familiar with this, but just to recap. So pre-contemplation is the idea that I don't have any contemplation that I have a problem. It's somebody else's problem, or it's not my problem. And it didn't really occur to me, and I'm not really ready in any kind of manner to even take a look at the problem. So they're even not in a state of contemplating or considering there's some kind of problem going on related to substances. Now, sometimes they may have a contemplation or preparation or readiness for dealing with, say, depression. But when it comes to my drinking, I'm really in pre-contemplation because I don't think that has anything to do with it, and I'm not ready to consider that at all. So you see these variations along the way. Contemplation is like just I'm thinking about it. I'm giving some consideration. I'm thinking that maybe there's a problem here that I ought to take a look at. Maybe my second or third DUI had something to do with just my vehicle or my taillights or those kind of things. Maybe it had something to do. Maybe she's leaving me again or he's leaving me again. And maybe it has something to do with my substance use. So there are these considerations that it's bouncing around in somebody's head that maybe there's something going on here. And usually this stage, you still got to recognize it. You got to begin to take responsibility for it. And you kind of move from pre-contemplation through contemplation to preparation. And then preparation represents this idea that I don't think this was in Prochaska and De Clementi's model, but with time and research, they added it. But preparation is that period when I am preparing to. So I may be contemplated, and I do think I have a problem, and I'm preparing myself for my situation to be able to take action. So sometimes, you hear this in, I'm taking care of things at home, so I'll be able to go to treatment or whatever I need to do and not have to worry though. I'm making sure that I got the insurance to cover me. I'm making sure that I'm getting some things done, ready to go. I'm making sure that I got daycare. I'm making sure these kind of things. So, and they may begin to make some change, but it's not the kind of direct action that we're looking for in the action stage, which is I'm basically in the changing process. And action can last for some time as people change, the people, the places, the things they hang around with, and the things they do. So action can last a long time. And probably, as I remember De Clementi and Prochaska describing this is not a straight line. This is like a cyclical kind of thing, like a slinky, and it just you go forward and you go back and you go forward and you go back and you go forward, but all the time you're kind of moving forward. So preparation and action, and then you're back to a little bit more preparation, and you're back to a little bit more action, and then more preparation and action. So you're kind of moving along in a recursive kind of fashion. So the action is where you're doing it, and that's where you're making the change. Now, at some point, you're not drinking. A person's not drinking anymore. They have some reasonably good abstinence behind them, or whatever their treatment goals were. They have some skills to maintain that. And so at that point, they're kind of in a maintenance phase. And so they're able to maintain. Now, there may be things that happen to them that cause them to lapse or to relapse. But basically, they've got the skills and they've got the resources and they've got the mindset to be able to maintain where they are. And so then they would be considered in a maintenance. And then they've added relapse here because lapses or relapse would be kind of a short use of substances without the change in thoughts and behaviors and relationships and all those kind of things. Relapse is more of a sustained return to use with relationships and thoughts and feelings and those kind of things. And so anyway, so enough said there, but these are the kind of things you're looking at we're talking about dimension 4, which is the readiness to change. And so this is how we think about readiness for changes. So when we're ready, what we're looking for in the ASAM criteria, somebody here who's in preparation and action, they're ready to go. Or if they're not and they're in contemplation, then we're not going to put them in a spot where we're asking them to make some significant kind of changes. We're going to work with them to help them bring them along to preparation and then action. So we want to time the intervention with where the person is in the continuum of change. So the other area you want to take a look at would be risk assessment. So I'll spend a little time with you going through the Columbia Suicide Severity Risk Scale. And it's not really my job to teach you how to score this and all this kind of stuff. Mainly what I want to do is kind of show you the big pieces of a good self-harm risk assessment, suicide risk assessment, and kind of walk you through the big pieces. So when you're sitting with somebody and you're doing this ASAM criteria and you get to risk, you're able to kind of think through, now, in this area, where are they? In this area, where are they? In this area, where are they? So this is kind of what we would look at. So this is a suicidal ideation. So these are kind of things we're interested in. This is a person wish to be dead. So this is kind of vague, wish to escape or to wish to be at ease or those kind of things. So you could think, I wish, have you ever wished you were dead or wish you could go to sleep and not wake up? So you hear these kind of things sometimes. So these are vague thoughts of not being, going to sleep, not waking up. If I died, it'd be no big deal. And then you got two kind of more specific, these are beginning to be more active kind of things. And so, have you thought of killing yourself? So this is more than just if I get hit by a bus accidentally, it'd be no big loss to me or my family. This is like, I've had some thoughts about not being, I've thoughts about actually killing myself. So we've upped it up a notch here. So you've actually had thoughts about killing yourself. You actually had some thoughts about taking my own life. I actually had some thoughts about dying. I actually had some thoughts about ending it all. So now then we've kind of bumped it up a notch. And then 3, you're talking about active thoughts, but no real plan without any intent to act. So you've been thinking about it and how you might do it. Yeah. So you hear somebody say, well, I've thought about it. If I was going to do it, I'd probably take some pills. Or if I was going to do it, I'd probably jump off the building. If I was going to do it, I'd probably have a car wreck. If I was going to do it, so, but I'm not planning it, when, where, and why, and I don't have intent to do it. But I think if I was going to do it, I'd probably overdose. So these are the persons thought about dying. They've thought about ending life, but it's non-specific, and they don't have a plan. But they've thought enough about it. Like with the one above, wish to be dead. I'm not really thinking about having a plan. But if I died, or it'd be no big deal to anybody, or if something happened to me, at least I'd be out of my misery. Or, if I died in my sleep, it'd be over. Now you're talking about somebody in 2 who's actually thought about, their death. And I mean, think about how exactly they're going to do it or when they're going to do it. And they don't not have intent, but they thought if I was going to do it, I'd take some pills. So then you got the non-specific. So you've had some thoughts about killing yourself. And then what I was just talking about was that if I was going to do it, this is how I do it. And then 4th, you're going to have some active suicidal ideation with some intent. So here it is, I have thoughts, but I definitely will not do it. So they don't have a plan. But if I was going to do it, this is how I'd do it. But I'm not going to do it. So I've had people, say, if I was going to do it, I'd do it this way. I know how I do it, but I'm not going to do it because, or I'm not going to do it till when, or those kind of things. So in that case, you've got somebody who has ideation, they got some planning, and so forth. So let's see here. So active suicidal thoughts of killing oneself, or a person reports having some intent to act on these thoughts, as opposed to I have the thoughts, but definitely will not do anything about it. You have had these thoughts and had some ideation on acting on them. So that kind of describes it. And then you have active suicide with a specific plan and intent. So I got a gun and I got a bullet and I got a time and I got a place and I'm planning on shooting myself. Or I got a rope and I got a tree and I'm planning on hanging myself. So what you're looking for here is this is kind of, as you go down the list here, the intensity of the suicidal ideations and the seriousness of them increases. Just kind of a way to know and to gauge, and some ideas about kind of questions to ask. Now then, the Columbia is going to talk about intensity. And so here again, this is just kind of, it's a guide. And really, you're talking about lifetime and recency. And 2 years is kind of a cutoff. If anybody's had suicidal ideations in the past 2 years that have been pretty significant, you need to pay attention to that. But, if somebody's had them, when I was, 15 or something, my best friend left me or whatever else, we moved across, and I, was thinking about taking some pills or took some pills, and, I'm 52 now. I don't have had any thoughts since. That's very different than 2 or 3 weeks ago. I was sitting there at the table drinking and had a gun in my hand. So you always need to ask about past suicide, past suicidal ideation, past suicide attempts, because today I'm just fine because she's home and we're happy. But 2 weeks ago she left. I was drinking and I was about to shoot myself. So that's that intensity and frequency and history are important. So how fleeting they are. Some people talk about having suicidal thoughts on a regular basis. Some people talk about them having periodically. particularly if they're, having thoughts that are pretty persistent. You need to kill yourself. Life's not worth living. Nobody likes you. This is the only way you're going to get out. There's no way to, improve your situation. You're stuck. Then, and by the way, legal problems or those kind of relational problems, legal problems are always high risk kind of factors where somebody feels like I'm going to be going to jail. There's no way to repair this relationship. I'm caught. Sometimes I remember a patient I had, very suicidal because he got caught, molesting his stepkid. And so we considered that to be, pretty lethal attempt because he was looking at some significant problems, both in terms of his relationships, in terms of his job, and in terms of his legal situation. Controllability is how can you combat these and can you manage them? And some people talk about they're being overwhelmed by them. They don't have any ability to control. Some people say, that, I'm able to talk back or I'm able to put them aside or I'm able to do that. So they're able to function pretty well. Deterrents are going to be, what gets in your way. These are mitigating factors. I have friends, I'm forward thinking, I'm seeking help, those kind of things. I have firearms at home. That's always a question I like to ask when somebody's talking to any about suicide. I was like, do you have access to firearms and how easily do you have access to firearms? So if you're going to, so you know what the factors are that are deterrents, so these would be mitigators. And then reasons for what's going on. And these range from, trying to get attention because she or he left me or whatever else to, I just want to stop the physical or the emotional pain to, there's no way to get out of my situation. So I'm going to lose face. I'm going to lose my income. I'm going to lose my license. And so there's no hope. So these are the kind of things when you're talking about intensity that you need to take a look at and consider. Carefully. I want to go ahead and close that. That means. So then you want to know about actual attempts. And so the more actual attempts, obviously, the more serious the potential for suicide is. And of course, within the last 2 years and the closer to, the more frequently and the closer to the day, the more serious or potentially lethal the suicidal thoughts are. Like we were talking a minute ago, if it's been a long, long time and things have changed significantly, then that reduces some of the risk. And then we're talking about interrupted attempts, self-aborted attempts, and preparatory behavior. So interrupted attempts would be, I had the gun loaded and I was sitting there at the table when the kids came home, and so I put it all up. So that would be an interrupted attempt. Self-aborted attempt or self-initiated attempt would be, you ever see that movie Man on Fire? So Denzel Washington's there, he's drinking and he's going to shoot himself, and he pulls the trigger and the primer doesn't work, and he calls his best bud up and says, do you ever hear of a primer not working? And the guy says, yeah, I've heard of it. And he says, the bullet tells the truth. And so anyway, later on in the show, he gives that same round to somebody else, and they do shoot themselves. And so kind of interesting, but that would be an aborted attempt. So the gun didn't work, the primer didn't go off, those kind of things. Or I was there ready to do it, and somehow I stopped myself and I didn't do it. So those would be, so that increases kind of seriousness. And then preparatory behavior. So I'm going to shoot myself, and I purchased the gun and got the rounds. And I know the kids and the wife are going to be gone, next weekend. And so I pulled a mattress around and put it in the shed. And when they're gone, I'm going to shoot myself. Or I heard one not too long ago, adolescent or something, and actually took a bunch of over-the-counter medications at night before they went to sleep. And never told the parents, with the intention that probably they were going to just die in their sleep. Mom happened to come in, noticed that the kiddo's bathroom light was on, went in there and to turn it off, and noticed that for some reason just kind of checked the medicine cabinet, noticed that there was a big bottle of something or another sitting there, and she rattled it, knew it should have something in it, but it didn't. And so she woke the kid up and then got him to the hospital, and the kid was saved. So here again, you got preparatory behavior where the kiddos got the medicine, planning on taking it when they go to bed. Parents will never know, wake up dead in the morning. Now, whether a kiddo really knows the seriousness of that or what the permanence of that is, I don't know, but it doesn't really matter because that's a pretty lethal combination. And so then last, you're going to do this kind of summary thing where you're going to take a look at what's the actual lethality and damage. And so if you're shooting yourself, that's pretty dangerous. Jumping off of a tall bridge is pretty dangerous. So that's cause a lot of damage or potential lethality. So you kind of put that together and come up with your idea for risk. I just wanted to spend some time and go over that because it's really important for everybody to be aware of. So a couple of other things before we get to some cases. So withdrawal management. So we got 4 levels here. So the green is kind of outpatient, secure at home. Things are going well. We don't anticipate any problem. There's a small likelihood that the person have any physical reaction, withdrawal, seizure, those kind of things. Maybe some discomfort. May not feel like, getting out and doing regular activities, but pretty much can be managed at home on their own. And then you've got intensive outpatient. So you're going to need, let me back up. So with withdrawal management, when it may be that, there's some medications that can be used to help minimize the withdrawal symptoms. Sometimes, and that will have somebody just come in for, 4 or 5 days, come in once a day. Nurse takes their blood pressure, ask how they're doing, assess their withdrawal symptoms. If we need to give them a little bit more Valium or whatever they're doing, we do that, or whatever they're giving them, and expect to see them again the next day, call if there's any problems. So that would still be one. Number 2 is where you're going to need some intensive outpatient. So you're going to need some actual kind of monitoring. So what I just described is kind of in between 1 and 2, but they're likely to complete without any serious withdrawals, but they need to have a lifeline, and they need a call. They need to be seen every day, and they need somebody to monitor them. So with an intensive outpatient program, we're going to see them several times a week. You're going to be monitoring, may well have them on medication, and there's kind of backup plan for if you start to have certain kinds of symptoms, then you're going to call and we'll take care of you. Then you've got residential. So this is pretty significant withdrawals. We're going to need, around the clock kind of nursing staff, and you're going to need, regular monitoring, probably on every 8 hours or so. You may be dispensing medication. You may be doing it on a symptom basis. And you're going to need to keep track of them because there's some likelihood that they could have some significant withdrawal symptoms that would require more significant medical intervention. And then you got 4, which is, there's high likelihood you're going to have some severe withdrawals. There's going to be some instability. And we do that over in Edmond. We have an inpatient detox program. So somebody, we anticipate that they're going to have some significant problems. And it could be because of withdrawal. It could be that they've got cardiovascular problems. It could be that they have a seizure disorder. It could be whatever. And so we need to go ahead. There's medical justification to put them in the hospital. We're going to put them in the hospital for a week or so. And we're going to monitor their symptoms and provide 24-hour nursing care and physician visits to actively manage their medical withdrawals. So when we're looking at risk in the 6th dimension, so when we're looking at the 6 dimensions, here we are. We got, we just talked about intox and withdrawals, and then we got biomedical conditions, talked about those, and then these behavioral, emotional comorbidities, readiness for change, talked about that, a potential to continue to use, and the recovery environment. So when we rate those, we're going to use this little scale here, 4 being, utmost certainty. The patient presents with critical impairment in coping and functioning, signs and symptoms of imminent danger. So this is somebody who we're pretty sure they're going to have withdrawal problems, or we're pretty sure they can't sustain abstinence, or we're pretty sure that their recovery environment is not going to be at all conducive to any kind of recovery. And then 3, you've got some serious issues or some difficulty with coping in a particular dimension. The patient is presenting at this level of risk maybe considered in or near imminent danger, but not in imminent danger. So it's something we really want to keep our eye on, and we need to react pretty quickly to it if we see that things are going south. Number two is going to be moderate difficulty. So this is going to be a significant challenge for the person. It needs to be monitored. We need to watch that. Yes, their depression could come back. They could get pretty anxious, but with some help and support and with some hard work, we ought to be able to manage that. And then one is going to be, mild difficulty. So it's going to be a road bump. I mean, it's going to be something that we're going to pay attention to. It's something to be addressed, but it's something that, the person should be able to get through without any problem. And in the past, they've been able to do that. And then 0 is very low, or we don't see this to be a particular problem at all. So the person's going to a house that supports recovery, and there's no substances in the house to be used. And the people there support his or her recovery, and they'll be monitoring the person, and the person has a good relationship with them, and those kind of things. So we'd say, well, recovery environment is 0. But if they're living under a bridge somewhere with a lot of other people who are using substances, there might be 4. So these are kind of the scale that we would use for risk on the 6 dimensions. So here are the dimensions. I would just kind of go over these to kind of show you, just pick out a few. So we've talked about withdrawal, but, biomedical would be, 0, healthy as a horse, no problems at all. And then you get down here to 3, it's like, tolerates and copes poorly with physical symptoms, has, a poor general health, doesn't take care of themselves. So here we're talking about, much more severe. If we're looking at emotional problems, 0 has got good impulse control. We can cope pretty well. Really no risk with depression or anxiety. Life areas are pretty good. Got in fairly good impulse control otherwise. That's where if you get down here to 4, this is severe emotional or behavioral symptoms that place the person or others at an acute risk of harm, intrusive thoughts. And so we see somebody here that maybe psychotic, somebody here maybe have delusions, something like that. So this would be our imminent risk. We can just pretty well anticipate that the person's going to have some problems. All right. So readiness for change. Let's just take a look here. So 2, this is one of those areas. 0 is none, and 2 is there's something we got to pay attention to. So minimal recognition or understanding of relapse and recidivism issues displays moderate vulnerability to further substance use. Some coping skills inconsistently applied. So this is somebody, who may not be able to fully recognize the cues for using. They might not fully be able to implement refusal skills, or they might not fully be able to use some of their, arousal, techniques for reducing arousal effectively in certain kinds. These are people that may be particularly susceptible to substance abuse. Social pressure, those kind of things. So that would be kind of a 2. And then, continued use. Let's see here. So 1 would be somebody recognize relapse issues and preventive strategies, but displays some vulnerability. So here, let's go back here because this is readiness to change. No, deal got in the way. So this is really somebody who. This sounds to me more like, being at a relapse risk. But this is somebody, let's see. So 3 may be a little bit better. So displays inconsistent compliance and awareness. So this is somebody who's not, they're probably still kind of contemplative. They're not really sure. That's where if you're looking for somebody up here who's very cooperative and motivated, they're ready to change. And so there's no question. So these guys are really ready to be in the action phase of making changes. And this potential for reuse, I think, is, and the readiness for change get a little bit, they're related, but they get a little bit confused, just like they did me there. And then recovery environment really has to do with where the person's going and where they're going to be living, and how supportive is that. So you look here, number 1, engaged in a structured, meaningful activity and has a supportive, significant other, so forth and so on. So that person is going to a place where they're going to be supported by others. They're going to be in a place where there's not going to be opportunities for use. They're going to be engaged in some meaningful kind of things. They're not going to get bored, start wandering off. If you look down here at 3, in terms of recovery environment, It's not going to be very structured. It's not going to be very meaningful. And, there's not going to be a lot of significant others living with them who are supportive, maybe actually unsupportive. And there may be some, significant criminal justice system involvement. So think about some patients, that's sent home and, they were going to be isolated and their family is going to be supportive and they were going to have something to do. And so we could feel pretty comfortable about the recovery environment. And then you talk to people, they think, well, I just quit. And I'm going to go back to the same old environment with the same old people doing the same old things I used to do. And you think that's just not a very strong recovering environment. So it's kind of an example of how we would use the 4 levels of severity to address the 6 dimensions. So you need to really go to the full day program to understand kind of how you add, how you kind of tally these up. And really, a lot of times, we're not trying to tally up and get a score that tells us exactly what, we need to do. We're just using the 6 dimensions as kind of a way to assess and then kind of arrive at a level of care. But so we can see what these are. So early intervention is going to be somebody who's going to be on an outpatient basis. I usually think about this sometimes as education, maybe a few strategies, and some opportunities to cut down. Maybe somebody who has the potential to just lay it down, those kind of things. And so early intervention would be considered a 0.5, and it's outpatient. Then you got outpatient services. A person doesn't pose a real significant problem for intoxication or withdrawals. A person has a fairly good recovery environment. They want to change. There's some emphasis in change, or they're not at all sure that they even need treatment, but they're willing to engage because they're talking about their marriage or they're talking about their depression or whatever else. So they're really not ready to go to a residential or to an IOP or a partial hospital program, even though they may need to. So you're not going to try to, buttonhole them into a position or intimidate them or cajole them into a level of care they're not ready for. You're going to hold them back at a level 1 outpatient program, and you're going to work with them until they get ready and come to see the need for a partial IOP or inpatient or whatever it might be. And then level 2 is going to be your outpatient program. And it's going to be, 3 days a week for about 9 hours a week. And it's going to include education and group counseling and those kind of things. And then you can bump that up a little bit with increased nursing and medical observation and attention. And then you've got the partial hospital program. This is going to be usually they're about 6 hours a day, every day of the week. And so somebody there is going to be able to go home and stay home, but they're going to need that medical intervention and support during the day. So sometimes you see this with people who are more medically fragile. Sometimes you see this with people who have significant depression along with their substance use, or people who just, are at a point where they really need that kind of structure because they don't have a good supportive environment, those kinds of things. And then you got residential inpatient. So this is going to be medically managed, and there's kind of 2 levels. There's kind of low level management where there's a nurse available and maybe a couple times a week the person, and the rest of it's psychosocial intervention. And then you've got a high intensity residential where you've got a nurse available, and usually there's some nursing intervention on a daily basis, and you may have physician intervention or psychiatric intervention, once or twice a week. With the low intensity, you may have medical intervention once a week or available as needed. So those are your kind of your 3 levels of residential care. The other one is even more highly managed. You could have a lock unit there, daily medical, 24-hour nursing services. And then you've got medically managed inpatient. So here, it could be monitored where you're going to be in a detox unit, and you're going to be initially assessed medically by a nurse and then by the physician and everything. And then you'll be managed there if vital signs or if problems arise, and the physicians are called. And then you've got intensive medical detox. This is where the physician and the nurses are involved every day, all day, monitoring and supervising. So what we try to do is evaluate first and then assign the level of care rather than not assuming somebody needs residential and then we do the evaluation. So when you're looking at the ASAM book and you're going through the ASAM kind of training, what you'll notice there are these service characteristics. And so, these would be examples of service delivery and settings. For different levels of care, you'd expect different kinds of therapies, group therapy, family therapy, individual therapy, those kind of things. There might be some support system involvements like AA and other kinds of community programs. Periodically, if you're looking into the manual, there would be certain frequencies of a review and assessment, and then certain levels of staffing by education experience, and then different levels of documentation. So it's really a handy book if you're or handy system if you're getting ready to think about doing a program, or you want to do a program, you want to increase the program. It tells you kind of staff you're going to need generally, the kind of documentation you're going to do, how often you're going to need treatment reviews, kind of therapies you're going to need, those kind of things. So it's a good approach. So we'll stop there, and before we get into the vignette, we got about 10 or 15 minutes. Maybe we get over one or two of these. Opportunity to ask questions or make any comments. All right. So here's our first vignette. So this is Mr. Smith. And so he's a 58-year-old guy. He's been married twice, 12 years. He's got two teenagers at home. One's in college. He's a heavy drinker. He's been previously diagnosed with alcohol use disorder, kind of moderate level. He currently has some milder withdrawal from alcohol. With the history of no more than kind of moderate withdrawals, he had those some times ago. He stopped drinking about 2 hours ago after he was kind of confronted. He's been drinking for about 5 months, 6 months. He drinks about 5 to 6 drinks a day. He's got hypertension. It's pretty controlled with medications. Blood pressure is running about 140 over 100. He doesn't have any current mental health problems or significant relational problems or mental health problems in the past. He's a manager, and he's been, working the same job for quite a while, 6 years. And he stopped drinking in the past for 6 months, and then 1 year in the 2-year period, and he's used AA and counseling as help. So what do you all think about, you'll have to speak up now, so you'll have to unmute yourself. But what do you think about him? So in terms of, we'll just start with intox and withdrawal potential. So where would you kind of rate him? So there's the rating scale. So any thoughts on where you might rate him, or what your assessment might be? There you go. What do you think?
Well, he's got some things going for him.
Mm-hmm.
He's got some things going for him.
What's he got going for him? What's he not got going for him?
Well, it seems like he's got, I don't know for sure about his living situation, but maybe he lives in a place where he could have some support, or at least not be around other people who are drinking.
Okay.
He is having some mild withdrawals, so that makes him a little bit more of a risk.
Yeah. So maybe like you thinking 1 or 2 risk, or what?
Maybe 2.
Okay.
Because I don't know if he needs medical attention to completely get sober.
Mm-hmm.
He might.
Mm-hmm.
I don't know.
What do you think in terms of his biomedical complications?
Well, he's fortunate in that he doesn't have any significant health problems.
Right. He's got his hypertension there. We got to keep an eye on that, right?
Yeah, that's true. And it looks like he's got some supports around him.
I think his recovery environment's probably pretty good.
The
I'm guessing.
AA and counseling,
Yeah.
so
How about
maybe,
his, go ahead.
maybe he could do this outpatient.
Okay. So
If
you
he's
thinking
motivated.
level, let's see here. So let's go back. So his recovery environment, I'm guessing, is pretty good. I think his, it sounds like he has, so let's just go back a look here. So you're saying that in terms of his, he's got some risk here with acute intoxication withdrawal potential. He's got this high blood pressure thing. It could complicate his withdrawal. So you're talking, he's a little bit of elevation there. What are you thinking in terms of emotional, behavioral, cognitive conditions that would complicate?
Well, he's not talking. I mean, he seems like emotionally he may be okay. He's not. Well, I didn't read that he's suicidal or anything like that. So
No, it looks like he doesn't have much. Let's see here. It says he doesn't have any, significant history of current mental health problems or relational problems.
right.
So I'm guessing that he's probably pretty good there.
Mm-hmm.
And he has
Readiness for change? What do you think?
he has a history of relapse,
Yep.
over the years, and says he has stopped drinking in the past. And for a 2-year period, he was had AA and counseling. It doesn't say he's doing it currently. So there's no indication that he's, he has to have a drink in the past 2 hours.
Yeah.
So
2 hours.
I have no indication that he is ready to change his behavior.
So you think relapse potential is high, Rita?
I do.
Okay.
I do.
Good.
Yeah, because he has a history of stopping, starting.
Yeah, his problem staying stopped. Okay. So based on all that, Rita and Lenora, where do y'all think y'all ought to put him?
If he would be so willing. I don't think he needs a residential program necessarily. If he could do intensive outpatient.
What do you think, Rita?
Well, I'm thinking outpatient, the residential, I don't know yet. The outpatient service, because he has a job, and that's important.
Yep.
That he has a job and that he keeps a job. That's going to help with that insurance, most likely. I'm looking at outpatient service to intensive outpatient, only because he hadn't had a drink in 2 hours. There's nothing that said that he's wanting to change anything yet, but he keeps going back and forth. So it makes me think he wants to. I think outpatient to intensive outpatient. I like the intensive because he can go 6 to 9 hours a week, still keep his job, and have some more support system.
So one of the things with we need to do with our treatment, I mean, I think you're both on the right track. The only thing I'd add, is we have to make sure that we don't get dichotomous. So I think probably, he could do with you could split it either way. Like he could have an MAT program where he's going to be, on a daily basis monitored for his withdrawals, and be an outpatient. So he could be in an MAT clinic where he's going to get some Vitrol, he's going to get some naltrexone, or he's going to get something like that. His blood pressure is going to be monitored. They're going to give him some liver and Valium, whatever they're going to do. And they're going to help him get through the withdrawals. He's going to have to do that. So he may have to come by, be late to work or whatever else. So you could do that and put him in outpatient. Or if you thought he needed, more intensive outpatient, but he also needed kind of that more monitored withdrawal, you could do that still in an MAT clinic. But some combination of that sounds like that would be okay. What do y'all think? Anybody else think? Vicki, you got a thought? No? Okay. Anybody else? All right. So maybe that's we don't have time for it, but So here's the dimensions on the score, but this is, Mr. Jones is a little bit more complicated. We're gonna run out of time and not be able to do him today. But he's had some suicide and he's not quite as willing to accept that he's got a problem, although he's on some oxycodone for some back pain. And so he's threatening to leave. So this is a little bit more challenging, but unfortunately won't be able to do that.
Oh,
Yeah, we'll maybe have it again sometime. We're right at 3 o'clock or after. So, well, any other closing comments or questions?
I personally, I think if it's possible to try to put people in the least restrictive environment that you can, if they have the supports around them, I think it's a more humane way to do it. I think.
I do too, and I think we have to think creative about combining levels of care and not, watching the deal. You got to go through 20-something days or 30-something days before you can go to that and do that, or you got to fail this before you can do that. I think that just puts patients through a lot of unnecessary grief and expense. And I think that, being able to move quickly from one level of care to the next is important. I think a situation everybody doing pretty well. The wife leaves them, their relapse potential goes way up. They need to be in a pretty sheltered arrangement for maybe a week or two. Then they're ready to get out and go back to an IOP or something like that. So anyway, it's been good to present some good discussion. Next week we'll